question, but also difficult because we do a lot of clinical care around the hospital. Our main role, what we know for, is for caring for patients on mechanical ventilators. Are you familiar? Have you heard of mechanical ventilators?
I have, yes.
So this essentially they're machines, pumps, air pumps that we use to help people breathe or pump air into them and oxygen when they cannot do it themselves for whatever reason. Sometimes because, let's say you go to surgery and you go under anesthesia, your body stops breathing on its own, so you need a machine to do it for you. Or sometimes you get sick, you get a disease, something called pneumonia, it's an infection of the lungs. Sometimes the lungs are not able to get enough oxygen into the blood, then we use a machine to help the patients do that. And sometimes it's just to help the patients overcome a flu or some kind of really bad cold where it has weakened them. So we use a machine to help them breathe. So the vast majority of our job revolves around caring for those type of patients, anyone that needs any kind of what we refer to as mechanical ventilation, meaning it's an outside equipment that we utilize to help simulate or copy what the human body does, but through a machine. Mm-hmm. That's the majority of our work. But we also do a lot of care for patients that are recovering or any kind of pulmonary condition, or anyone that just had a surgery, or anyone that's suffering with chronic conditions or conditions that are ongoing. They don't get better. So we help them. We do a lot of therapy by doing like chest PT or that's when an RT will go on the back of the patient and help them mobilize secretions, move them. Sometimes we help them by giving nebulizer treatments. So if they can't breathe well, the doctor might prescribe to them either a medication to help them sort of breathe a little bit better by either opening the airways or by enhancing their ability to take a deep breath. So we give them nebulizer treatments. We make sure that the medication is going in there. We provide education for them and teach them how to do it at home. So we do a certain amount of education as well. Part of our job, Christian, also is we're very critical care center. And what that means is that we deal with very, very sick people. Not so much the people that are a little bit sick, but the sicker you are, the more likely you are to be serviced by a respiratory therapist. So I'll give you an example. Sometimes very sick people in the hospital stop breathing or their heart stops, right? So they're very, very close to dying. So what the hospital does, they call like a quick team to try to see if we can revive them, get them back to life, get them back going again. So the respiratory therapist's role is to go and run to the bedside where the patient is and try to secure an airway. What that means is we're going to try to get a tube, and we're going to try to put that tube as quickly as we can in your trachea and be able to provide air for you because you're not breathing anymore. When I say you, I mean the patient. The patient is not breathing anymore, so we need to artificially get the air into you. And for us to be able to do that, we need a specialized tube to go into your trachea, and then we use an artificial bag to push air into you and eventually hook you up to a machine that's going to breathe for you. So that's a lot of like the critical care response. They also call those when a patient is not feeling well. It's not yet, his heart hasn't stopped, he's not that sick yet, but he looks like he's going to get that sick. So they call us to help him assess the respiratory needs. Do we need to put one of these artificial tubes in there? Or do we need just to give him a little bit of support with a mask? Do we need to provide people with oxygen? Oxygen is another big thing that we do. So when we see patients, they call us and we have a little machine we put on their fingers and it tells us how well the oxygen is going into their bodies. And if it's not going well, we suggest and recommend giving them more oxygen than they usually get. And so that you know, just to give you a little background, you and I breathe 21% oxygen. So the air we breathe has only 21% oxygen, the rest is nitrogen. So when people get really sick, we change that around a little bit and we give them air that has a much higher concentration of oxygen, up to 100%. So we get rid of the nitrogen, we give more oxygen, hoping that some of it will get to them just to keep them going until they feel better. And that kind of sums up what we do. We do a lot of other stuff. We go to the ED. We also care for babies in the NICU, very sick babies that can't breathe well. We respond to you're going to find an RT in the emergency room. Anyone that's really sick and having respiratory issues, they're going to call us for it. You're going to find us in the critical care units where the very, very sick people are. That's the bulk of our work. But we also work in the recovery areas where the patients are getting better. We help them transition to like a normal sort of treatment as they get better and better.
Mm-hmm.
Just sum it up. I think it doesn't make sense to you. If it sounds weird, you start to say, hey, Leo, I don't know what you're talking about. Can you tell me that again? If I don't get it, I'll be more than happy to explain it to you because I'm talking to you. I deal with it daily, so I'm not sure what's foreign to you and what's not.
Okay. Yeah. That was good. Thank you. The next couple questions I have are just about like the beginning of COVID and everything. So, my next question is, why was the role of an RT so important during COVID?
Well, I tell you, during the first wave of COVID, each wave, for lack of a better word, season or each surge that we was a little bit different. During the first COVID wave, this was new to everyone, and RTs were critical because every single patient that came to the hospital with COVID, we were aiming to put that tube into the valve and put him into a mechanical ventilator. Every single person that came in with COVID. People were really afraid of all the patients. People were really afraid of getting COVID. And the decision along with the doctors was to anybody that would come in with COVID, they would most likely would go into respiratory failure, meaning like they will not be able to breathe. So the decision is, hey, let's put them on a machine as quickly as we can, see if we can contain the virus so it doesn't spread to the rest of the hospital. And because we know they're going to end up needing this anyway. So the thought of that is like, if we put them on anything but a ventilator, eventually they're going to end up on a ventilator anyway, and we're going to contaminate everyone for no good reason.
Mm-hmm.
So RTs were critical because we are the only ones that know how to operate those mechanical ventilators.
Yeah.
So doctors order them, nurses kind of watch out for them, but nobody in the hospital would know how to use a mechanical ventilator.
Mm-hmm.
So it's a very specialized role in terms of managing that machine and how it works and how much, what settings to put in it and how much volume, how much oxygen. So it's very specific to the respiratory therapist. So when you start getting all these patients that are coming in with COVID and the master plan is to intubate or to put people on mechanical ventilators, you're going to need all the RTs you can get because we are the only ones that know how to do it. So when you start getting 2 patients, 5 patients, 10 patients, quickly, it becomes a very difficult situation because the resources are limited. You only have so many RTs, and you only have so many machines. What do you do when you get the next 10 patients, and the next 10, and the next 10? And it's so unusual from what you do every day in terms of numbers. So that's why the RTs were so critical, because we had a very unique knowledge of how to utilize the ventilators, and the ventilators were the choice of treatment for every single COVID patient that came to the hospital.
Okay. Yeah, so that actually leads me to my next question, which is, what types of challenges did you guys face in the hospital?
What challenges do we have?
Yeah, like in the hospital.
All right. So the first challenge we had is we could only get so many ventilators initially because we weren't expecting the amount of patients at the pace that they came in. So the first challenge is, do we have enough machines to give everyone? What are we going to do when we run out of machines? We weren't expecting this many patients. And a challenge that's very closely related to that is like, oh my gosh, we only have 50 RTs. What's going to happen when more and more patients come in? No one knows how to use these machines as the RTs do. Where do we get more RTs? And because the problem, every other hospital had the same problem, we couldn't go out and get RTs from other hospitals. Usually, explosion or a local issue, you're able to reach out to other hospitals or other sites and say, hey, can you send me some of the RTs? We have an emergency. But this was widespread, meaning we had no options. We had no alternatives to get any more respiratory therapies. So now that was a huge challenge. How do we care for these patients safely with the very few RTs that we have compared to the amount of patients that are coming in? So the main two challenges is machines, ventilators, and the number of respiratory therapists. Does that make sense?
Yeah, that makes sense. My next question is, were you ever scared for your health when caring for the COVID positive patients?
Absolutely. Every single RT was petrified to go into a COVID room. I clearly remember the first patient we had. I was working at a different hospital from the one I work now with your dad. I was at LMH, Lower Manhattan. And then the first patient came in, and it was so difficult because everyone was very afraid. This is new. We know it's extremely contagious. We know it's lethal. It can actually kill you. So we're doing the best we can to protect ourselves, but of course, extremely afraid of it. But my staff was extremely brave. I mean, I remember one or two guys that were the first ones to care for them. They put the mask on, they put the face shield on, they put a gown around them, the gloves. That you can see the fear in their eyes, and I was there with them, and I was afraid of it as well. It becomes very personal because now you know that this can possibly kill you. But we have a job to do. This is what we signed up for. This is what we committed to, and we knew there was nobody else that can do it. So we had to do it, but absolutely terrified, yes.
Okay, yeah, I also just have a follow-up on a previous question. So, how did you guys in Queens overcome the challenges and shortages? And were there any creative solutions that you guys had?
So how do we overcome the challenges? Well, I tell you one by one. So when it comes to the lack of ventilators, we're very lucky to have a very big organization that has a lot of resources. So quickly, all the respiratory departments for the physician, we started a daily communication. And communicating daily about how many patients had COVID, how many ventilators did we have. We did an assessment of machines, and what options did we have to increase our numbers. So getting together and having that conversation and doing a daily assessment of the needs and the resources was crucial to get us by. Without it, we would not know how much we could actually, how many patients we could actually care for, or how many patients do we have to send to other hospitals. New York Respiratory Therapist was one of the hospitals that had the most COVID patients anywhere on the first wave because COVID was so focused in New York City. It was everywhere here, and we were the hospital that had the most patients at any time. So to overcome the stress of not having ventilators, of not having enough respiratory therapists, even nurses and doctors, I mean, everyone was completely strained. We had to communicate daily and said, what do we have? How many RTs do we have? How many ventilators do we have? How many patients can we care for? And then we all jumped into action to try to secure both more personnel, more therapies, and more ventilators. So the organization, believe it or not, jumped into action, and we reached out to some of the ventilator manufacturers and said, is there any machine that you guys have left over that we could possibly buy very quickly from you? So the organization purchased over 200 ventilators from the manufacturers that they were outdated, but still very functional. So we bought used, not just new ventilators, but outdated, like older models, like buying 2016 Ford, but it's new. So we bought many ventilators, and we came up with our own warehouse. So the organization came up with a plan, buy lots of ventilators, keep it in a centralized location, and based on the daily assessment, give out to every campus as much as they needed, or as much as we could. We also reached out to a lot of rental agencies. These are agencies that rent out equipment for hospitals when of course, there were very few because every hospital is putting resources. And then for the staff, we reached out to a bunch of agencies that provide respiratory services. We were lucky enough that COVID was very localized in New York. So there is a lot of from the Midwest, from the West, from the South that came here to help us. But that took some time. It wasn't immediately. So we reached out to them, but we did increase their staffing, double almost the amount of staffing that we had to help us care for these patients. We also, Christian, we reached out to everyone in the hospital to see how they could help us care for these patients. So nurses started doing a lot of the functions of the respiratory therapist did. They helped us with suctioning the patients and maintaining the airway. Some doctors started kind of learning the ventilator. We gave quick courses in how to do basic care on the ventilator, so it would help us kind of care for the ventilators. Physical therapists were helping us move the patients. The entire hospital kind of got together and said, guys, whatever rooms we had, we're going to have to be open and do something differently to make sure that we care for these patients properly. So every other discipline that wasn't as heavily utilized helped us tremendously, and they accommodated us and they worked with us to be able to do some of our work, so we were able to care for everyone. So we also had nurses. Would bring a lot of nurses from other places as well, and they would have like one nurse that worked in the hospital overseeing 3 or 4 nurses that are coming from other states. So it was sort of set up in a way that we have one very experienced person overseeing 4 or 5 new staff that's coming to help the hospital.
Mm-hmm. Okay. So that were some of the short-term, measures. So do you know if there were any long-term measures that were put in place to ensure that these shortages, don't happen again? If there's another wave or, another disease or something?
Yeah, we definitely got more organized in terms of permanent solutions. Like the hospital made the warehouse that I have spoken to you a permanent thing. So we have a stockpile of ventilators now internally available to us. We also had a commitment from some companies to provide us a certain amount of machines if we needed to on a flight. We bought some reserves, so we increased our reserves, strategic reserves of ventilators and oxygen devices. We have agreements with 3 or 4, maybe 2, I would say, at this point, like 2 personal agencies, and your dad's department is really helpful in trying to help us get the stuff that we need in short notice. So we have contracts and we have agreements and established processes for onboarding people very, very quickly. And those are being now sort of solidified to kind of help us there. Another thing, Christian, that has changed is that a lot of the patients that come with COVID now, they did not necessarily go on a ventilator. In fact, most are not. So we sort of, as a respiratory department, we're kind of changing our strategy on how we deal with these patients. The patients that are coming in are not as sick. Many of them are not going to the ventilator. In fact, we try to keep them from going on a ventilator because those patients didn't have a good outcome in the beginning. So we try and modify the therapies that we have available for them. Now, many of them get treated with devices known as high-flow oxygen devices. And that's essentially very fast-flowing air that's full of oxygen and it's humidified. And it's very comfortable, and it's been shown that it has very good outcomes with COVID patients. So part of the long-term goal is also to try to see if there's alternative treatments as opposed to just ventilators. So we no longer going specifically to a ventilator. We are trying other alternatives and options to treat these patients so they don't end up intubated on a mechanical ventilator, because the outcomes weren't so good when we first did it during the first round. And I think that's it. And we got really good at doing our planning. So we have a plan in place, a staffing plan that shows us or help us or guide us on what to do when the census, when the volume, when the amount of patients starts getting really high. It tells us, look, if the RT has to care for 6 people, do this. If the RT has to care for 10 people, do this. And if the RT has to care for 12 or more people, do this. So we have an algorithm that all the respiratory therapists in the hospital came up with that guide us in what to do during a search or during an emergency. So if we get 6 to 10 patients, let's get more overtime, let's get more staff here. If we have more than 10 patients per respiratory therapist, we're going to have to reduce the workload. We're not going to check every patient every 3 hours. We're going to check them every 5 hours. And if the census continues to increase, and we start seeing like 12 patients or more per respiratory therapist, let's make sure that we enlist the help of other people that might not be as busy. During the pandemic, people from the OR were not working as much because we stopped all the OR cases, and everyone was focused on COVID patients. So we enlisted all the OR staff to help us with some of the responsibilities that we needed to do. So that's part of our plan now. If we go to a certain number and we start increasing, we have an algorithm or we have a plan in place to deploy to start reducing the workload that the RTs do and start enlisting the help of all the other clinicians in the hospital that might not be as busy. So we have, just to recap it, we have a strategic reserve of ventilators. We are changing the way we care for those patients on the therapies. We are securing our staffing, and we have ways to bring staff into the hospital much faster. And we have a system in place that looks at the volume of patients per respiratory therapist. And depending on the volume, we enlist or we enact a plan to reduce the workload for the therapist or to get other clinicians within the hospital to help them.
So my next question is, how can we drive more people to the field of respiratory?
That's a really good question, Christian, that I wish I had the answer for, but we have some ideas. But this is so very new. I know because of COVID, our profession became a lot more visible. Before COVID, not many people knew what a respiratory therapist does or about the profession. It's a rather small field if you compare that to nursing. Nursing is huge, right? It's probably one of the biggest occupations in the country. The respiratory therapist is a little more obscure, less known. So this COVID, believe it or not, has brought a lot of light to what we do within the hospital. And a lot of people are a lot more familiar with the concept. We have a lot of schools in the area. We're lucky enough that in the Northeast, I believe we have 6 or 7 schools. Many of them, they used to be just an associate's degree. Now most of them are a minimum of a bachelor's to be a respiratory therapist plus certification, which is really good. I mean, what we're doing is working with our schools, trying to. We have publications. We have an organization. It's very well known within the field. The American Association for Respiratory Therapy. So they are in charge of sort of publishing and distributing information about the profession in many different forums. They have a magazine. They have a website as well. We have all the schools that try to reach out when a student goes into the liberal arts, or they're trying to find out what's good for them. Many of the schools have programs to showcase what we do and to give education to the new students to see if that's something that will attract them. And we often get invited to the schools to have events where we explain what we do, just like I'm doing it with you right now, where we speak to students and see if that's something that they might be willing to do for a living, and we tell them a little bit about the profession and what we do. So there's different things in from different entities that try to aim to expand the knowledge of what our respiratory therapists do. But I think that COVID has definitely given us a huge boost in terms of people knowing who we are and what we do, and the availability, and just to showcase what we do as a profession to everyone.
Mm-hmm. So I'd like to help. So I'm going to reach out to the New York City Council to pitch them on new RT programs, and I was wondering if you have any suggestions about that.
Well, that is awesome, Christian. I'm very happy to hear that. And can I ask you, Christian, what interests you in specifically the respiratory therapy profession?
So my coach, in the beginning of COVID, he passed away. He was one of the first people to pass away, and then so that really, hit me. And when I learned the way he died, was through his respiratory issues, and then my grandma also had some issues with the respiratory as well. So
got it. So for your a suggestion for, if you want to bring this to city council, to be honest, education to him and to give an understanding what the necessity of respiratory therapy is, how vital our profession is in times of disease, and respiratory diseases are here to stay. They're not going anywhere. Before COVID, we had our biggest population were the COPDs, chronic obstructive pulmonary disease, which is very, very common. I think it's the third or fourth leading cause of death in the U.S. right now. So just your job, you can contribute to the profession by just making sure that the councilman or whoever you're speaking to is aware of the need to increase the number of respiratory therapists, to facilitate programs, school programs that help educate more people and become respiratory therapists in the long term. So that's the things that's really the things I can think of, that maybe sharing your experiences with him and telling him, look, there's a need for this profession. We don't have enough of them. How can we facilitate education? Because the jobs are here, Christian. We just need more staff. So we just need more. We need to produce more. We don't have enough respiratory therapists right now. So it has to start with the schools. It has to start with adding new programs to what we already have, making it more available to people, and reaching out, really making that connections from the high schools to the colleges, and create more awareness of the profession, see if anyone will be more interested in it as well.
Yeah, so that's very helpful. Thank you. And I'd like to end by just saying thank you for taking the time to meet with me, but more importantly, for saving all the lives.
Oh, well, anytime. You're very welcome. It was a pleasure. You can call me anytime if you have questions, or you can tell your dad to reach out to me in the job. I'll be more than happy to answer any of his questions or yours.
Okay, thank you.
All right, you have a good night.
You too.
Thank you, appreciate it. Bye-bye.
Bye. Oh, I'm so scared. Hit pause.